Hi everybody, I'm just a 20-minute talk and I think a lot of what I'm about to say has been said, so we'll keep it fairly short before lunch. I'm Suzanne Ryan, I'm a GI radiologist and I've been asked to talk about the imaging management of incidental focal liver lesions. And we're all aware that the number of examinations we do increases manifold every year, and therefore the number of liver lesions and incidental liver lesions that we pick up increases manifold per year. So what do you do when you're scanning the patient and they're staring at your face and you say, I think I see a liver lesion, and then you look a bit closer and you think, I definitely see a liver lesion. And then the patient is at this stage hysterical, wanting to know what's going to happen to me, doctor. So you have to have some sort of an imaging strategy or a treatment strategy for these patients before they leave your ultrasound room so that they don't go off, obviously, and commit suicide or worse as they wait for their next test. What should we call them? When we're discussing it with a patient and we've picked up an incidental liver lesion, we know that most of these liver lesions are benign and incidental and not ever going to affect the patient. So you want to have a nice sort of clear name for them that isn't too threatening, and I think focal liver lesion is a good name. It's neither saying it's benign or malignant, and it's saying it's neither solid nor cystic. It's nice and kind of a nebulous thing to say to the patient. It can be difficult straight away on your grayscale imaging to differentiate benign from malignant, and some non-cancerous lesions will have malignant potential, so you have to have a sort of a treatment strategy or a spiel to give the patient before they leave. But the most important thing to remember is that it's probably not going to be something that's ever going to cause them further concern. When you're scanning the patient, as Prof. Lim was saying, you have the patient in front of you, so you can use their age, their sex, whether they have used oral contraceptives, whether they've chronic liver disease or recent travel to help you try and diagnose the lesion and prognosticate. And the useful thing to remember is that if it's a small lesion, it's probably going to be benign. So less than 1 centimetre is probably going to be a benign incidental finding. So the American College of Gastroenterology has helpfully given us a handy flow sheet for these patients. The management of focal liver lesions is recognised as a problem both in radiology and in all the medical imaging specialties. And breaking it down, if the patient has a known risk factor for HCC or a known malignancy or elevated tumour markers, then you're pretty quickly going to get them on to have a CT or an MRI scan to evaluate the liver lesion and to look for lesions elsewhere and characterise it as HCC, metastases or other. I'm not going to dwell too much on these because it's not really under the remit of following up incidental liver lesions. They'll go for a scan to look for a primary or to characterise. If you come across a cyst, as you frequently do, and you're happy that it's a nice simple cyst, then that's fine. The patient needs no further follow-up. If it looks a little bit complex or worrying, then you can give some contrast ultrasound on the day and make your diagnosis. They're common lesions. You can tell the patients and send them on their way. Excuse me. So if it looks like this, with no enhancement whatsoever, no vascularity, no walls, this is a simple cyst, and the patient does not need to be seen again, and we can give them the diagnosis before they leave. If you're concerned about the matrix of the cyst, you may go on to do an MRI, which will be low on T1 and high on T2, and may show some enhancement. And if there's hemorrhage, I think that's where an MRI can be most useful, just allowing you to look at different signal intensities according to the different heme components of the lesion. So just a T1 and a T2 of a hemorrhagic cyst, and you can see its high signal intensity, and then we can see some layering within that allows us to be confident that this is all a hemorrhage within a cyst with no enhancement on the contrast phase. What about biliary cystadenomas? Well, we can prognosticate again according to where the lesion is, if it's got complex features, what age the patient is, and how it appears on our imaging will depend on the components of the biliary cystadenoma. This is just an incidental cyst picked up on a 50-year-old lady on ultrasound, a bit of through transmission, and she went on to have a CT scan, which we should quickly play through, and you can see that there are 2 cystic lesions, no significant enhancement, but she does have biliary dilatation. You may see polypoid excrescences and enhancing nodules. They don't necessarily mean malignancy, but they can make it more likely to be malignant. We can also look with MRI, and this is the same lady with MRI. And again, it'll be low on T1 and high on T2, depending on the components of it, with some biliary dilatation. Now, we would recommend removing these lesions and not really following them up ad infinitum in a perfect world. But this is an old woman, she's got a hiatus hernia, she's got multiple comorbidities, she's got rectal cancer, and so we've just been following her up on a yearly basis. Initially, we will follow the patients up with MRI and then onto ultrasound if they show lesion stability. You can sample the fluid, and some sources advocate sampling the fluid, but it's not necessarily going to differentiate between benign and malignant, and there is a risk of seeding with passing the needle through the liver capsule. And so we would advocate removing biliary cystadenomas. If the patient is too old or unfit, then we will follow up with MRI, followed by ultrasound when lesion stability is demonstrated. If we pick up a hemangioma, we will give contrast, and if we show the characteristic enhancement signal, we will then go no further. These patients do not go for CT or MRI scan. Once we see our peripheral enhancement pattern, the patient goes no further. They need no further imaging and no further follow-up. Fatty infiltration, a very common finding. There are some characteristics areas where we will see it, and more often than not, you know it's fatty infiltration. But occasionally it can have a very mass-like effect. And so if we look at the grey scale of this patient, adjacent to the gallbladder, here's the gallbladder, and here's our fatty infiltration, and it looks quite mass-like. And we want to send the patient away. We don't want to see them again. We don't want to have to do any other further investigations. So if we give contrast, and here you can see why it's useful to split the screen, because you may lose the lesion with that, but here's the gallbladder, and we can see that this lesion, as the patient breathes in and out, is enhancing the same as the background liver. So again, this patient has their diagnosis made. They do not need any further imaging, and they do not need any further follow-up. Okay, so those are the easy lesions that we can make our diagnosis and send the patient away on the day. What happens if we see a solid lesion? We can't be quite so sure. We'll have a well patient in front of us. We'll think it probably is a metastasis. So if we give contrast ultrasound, it will help us to triage the patient and their follow-up. If we give contrast ultrasound and it shows enhancement on the arterial and venous phase, it's more likely to be benign. And if it shows washout in the venous phase, as we've heard, it's more likely to be malignant. So if we're seeing this hypervascularity on the arterial phase with washout, they will go on for other imaging strategies and potentially biopsy. So we're moving them away now from our follow-up field. And if we give contrast and it's enhancing on the arterial and venous phase and we see a scar, it's more likely to be an FNH. If it doesn't have a scar, it may be an adenoma or an FNH or other and need further characterization. So we will then send them down this pathway where we'll send them off for an MRI. We know the vascular characteristics. We don't have a great need to do a CT scan. We're fairly sure this will be a benign lesion because it's holding on to contrast on the arterial and the venous phases. And so we'll send them for an MRI plus or minus hepatobiliary agent. If we see a scar, we're fairly sure it's going to be an FNH. If we don't see a scar, we need to keep going a little bit, and we will then use our hepatobiliary contrast agent. And if on the delayed phase it's holding on to it, it is usually going to be an FNH, and if it's not holding on to it, it is usually going to be an adenoma. We won't always see a scar in FNH. Generally, if they're bigger, we will see a scar. If it's smaller, we may not see a scar. It doesn't mean it isn't one. It just means we need to follow it up a bit more closely for the beginning. The difficulty in differentiating between FNH and adenoma is that they are pretty much in the same group of patients with predominant female occurrence occurring in the 3rd to 4th decade of life. There may be a history of oral contraceptive pills. The fact that there are multiple lesions is not that helpful because 10 to 20% of FNHs may be multiple, but if you see hemangiomas, then that might veer you towards being an FNH. And you can also get multiple adenomas as well. I think this is a useful statistic. FNH is the second most common benign hepatic tumour, occurring in 8% of primary hepatic tumours, whereas hepatic adenoma is occurring in 1 in a million patients. So if you're a betting person and you're trying to decide what's this lesion going to be, it's probably going to be an FNH. It is important to try and differentiate them because, as we've heard, there is an incidence of hemorrhage and malignancy within subtypes of hepatocellular adenomas, but it tends to be with the larger lesions. So if you have a smaller lesion, you probably have a bit more time to follow up this and not necessarily rush into treatment or excision or biopsy. The delayed phase imaging, the hepatocytes phase imaging and MRI is crucial in helping to differentiate and prognosticate for the patient. And FNH, because of its protein transporters, because of its matrix, tends to hold on to the hepatocellular agents on the hepatocellular phase, whereas adenoma tends not to. And this is thought to be secondary to the OP protein transporters. It's not 100%, but it's fairly high up there, and so that's a useful way of deciding between the lesions if you're not going to biopsy and if you're going to follow up. Now, this is a busy slide, and I would bear in mind that hepatocellular adenoma accounts for one in a million of our lesions, or well, not 1 in a million lesions, but 1 in a million people, and not get too hung up about it. But they've worked out the genetics and the phenotypes of these lesions and their characteristics in MRI. And so if you're trying to be clever, we can look and see that some of them will show more fat, and so will have signal loss on chemical shift. Some of them will be more likely to bleed and hold on to contrast. Some of them will show a washout. So it's not definite, but you can go through this algorithm with your MRI. I'm not going to go through it now. I think you probably look it up as you were doing it, and try and prognosticate which lesion it is. HNF1 alpha accounts for 30 to 35% of adenomas. Inflammatories are the most common. The beta-catenin is the one with the malignant potential, and the inflammatories can bleed and the beta-catenins can become malignant. The unclassified accounts for 10%, and it's thought that they may be unclassified because a lot of these have hemorrhaged, and so the imaging characteristics are difficult to work out. FNH has different cellular types as well, just to show that it's not been left behind in its complexity. So again, they'll all have general imaging characteristics, but not every lesion will show them for definite. So if we're scanning and we come across this well-circumscribed lesion and we give some ultrasound contrast, and we can see that it is going to avidly enhance relative to the background liver. Here it is, and there's the background liver on the arterial phase, and we can see it's holding on to contrast on the portal venous phase. And looking at that arterial phase, it doesn't have that spoke wheel enhancement characteristic. We know it's likely benign. It doesn't have a scar. It's probably going to be, or it may be, a hepatic adenoma. If we're scanning this patient and our grayscale shows us, again, a well-circumscribed lesion, the Doppler is not that useful. And then we go on to give contrast, and we see on the arterial phase and the very arterial phase this spoke wheel enhancement characteristic. And then it holds on to contrast on the portal venous phase. Again, we think this, because it has a scar and because it has the spoke wheel enhancement, we think this is likely to be an FNH. And then I just threw in another FNH because I couldn't resist. So you can see this is sort of a nice spoke wheel enhancement characteristic holding on to the contrast and the scar, so most likely an FNH. On MRI, FNH will have imaging characteristics that are only for it. It will show that it has the scar. With MRI, you may get delayed enhancement of the scar, whereas with contrast ultrasound, the scar doesn't enhance at all because it's a truly intravascular contrast agent. And it will hold on to contrast, and it will hold on to our hepatocyte-specific contrast as well. So they will have their scan and then go on to have probably an MRI. This is just a gadolinium MRI, T1, enhancing arterial and continuing to enhance, and then you can see delayed enhancement of the scar. And this is taken from Grazioli's paper, which shows enhancement and then holding on to the contrast on the delayed phase with a scar centrally. And this is again from Grazioli with biopsy-proven FNH holding on to contrast on the hepatocyte phase, and the adenoma, biopsy-proven adenoma, losing the contrast on the hepatocyte-specific phase. We've heard that there is some crossover, and we have to be careful between hepatocellular adenoma and HCC. A small percentage of the inflammatory HCAs will show arterial enhancement and rapid washout. They can mimic each other, basically. So nothing is definite. We do have to follow them up. There will be lesions we have to biopsy, but in general, there are broad imaging characteristics that they will conform to. The risk factors for malignant transformation for hepatocellular adenoma is the male sex, glycogen storage disease, steroid use, and the beta-catenin mutated subtype, and also size greater than 5 centimeters. So our follow-up then is if we see an FNH on contrast ultrasound, we will go on to our MRI usually to confirm the diagnosis. We don't routinely biopsy if we're happy that it's an FNH. We don't stop people getting pregnant or stop them taking the pill or their steroids. And we don't really think they need any intervention. If they are going to continue with the pill or if they're getting pregnant, we may do an annual ultrasound just to follow it up. This started off as an emoji, but I don't know, it got transmuted into kind of a monster. This is supposed to show women, that they're more common in women and they're larger, and women present with earlier lesions than men. So they thought maybe the pill had something to do with it, but they found with increased use of the pill over time, it hasn't led to an increased prevalence, and they don't particularly increase with pregnancy. So there isn't great evidence to say don't get pregnant and stop the pill. Okay, if we suspect a beta-catenin hepatocellular adenoma, then obviously we will refer for a section. We may biopsy. We need to watch these closer than the other lesions because they have a chance of becoming malignant, and they shouldn't show signal dropout on chemical shift imaging. So our advice for patients in whom we think have a hepatocellular adenoma is avoid the pill or any hormones. We will biopsy if the imaging is inconclusive or it's going to make a change in our treatment. We don't contraindicate pregnancy if they're less than 5 centimetres, but it is, as always, an individualised approach. And if it's greater than 5 centimetres, we definitely would recommend intervention. They will initially have a follow-up MRI, not a CT, at 6 to 12-month intervals. And then as the lesion becomes stable, we will follow them up with ultrasound. Again, just to put in the caveat, some hepatocellular adenomas will continue to increase in size even if the pill is stopped or the steroids are stopped. And there are reports of HCC developing in these lesions even if they get smaller in size. So it is important to follow them up by whatever imaging modality you choose, but either MRI or ultrasound. And then these are just some of our local images. This is the arterial phase of a biopsy-proven FNH, the portal venous phase, and on the coronal we have the hepatocyte phase. You don't see a scar because it's small. And then this was just from this week. This is a patient, I think, who has multiple hepatic adenomas, and this is an in and out of phase scan. Coming up to the out of phase, you'll see they're lipid rich, so they are going to lose, they've lost signal on the out of phase scan. And then on the arterial phase scan, we will begin to see this one up. Sorry, I can't really see my screen here. So they're almost iso-enhancing to the background liver on the arterial phase scan, remembering that we don't get such a great arterial phase with MR as we would with contrast ultrasound. And then on the portal venous phase scan, they're losing quite a bit of signal on the portal venous phase scan. That's another one by the IVC. On our diffusion-weighted imaging, we're not seeing them at all, which is reassuring, or not seeing them showing much restricted diffusion. And then lastly, on our prima-vis scan, we can see that they're not holding on to prima-vis. So we've been following these multiple adenomas for years. They're biopsy-proven. Okay, so on to the very last bit of the talk before lunch. Cirrhosis and a new nodule, we've heard about this, and size is the important thing here. If the lesion is less than 1 centimetre, it's unlikely to be malignant, and we would follow it up at 3 months, earlier than our normal follow-up time. If it's greater than 1 centimetre, then we're concerned. And we've seen a similar flow diagram in the last chart, just showing us that it's all to do with the vascularity of the lesion and the tumour invasion of the nodule, ultimately eating up the portal venous flow and the hepatic venous flow so that you get arterialization at the end at your cancer stage and hypovascular on the portal venous phase. But it's a bit in between that we are trying to catch. So if we find a lesion greater than 1 centimetre, or if the patient has an elevated alpha-fetoprotein, or we're concerned that there may be HCC, then we need to perform characterization with CT or MRI. Most of the HCCs will show this characteristic enhancement pattern on the arterial phase with washout, but not all. Biopsy can be used, but there is a risk of seeding, and it's useful to use a coaxial biopsy technique to minimize that risk. It's also important to note that hypervascular nodules can come and go in cirrhotics, and there's a wide spectrum of what they can represent. So a hypervascular nodule does not necessarily mean a HCC. And in one study, up to 25% of these lesions regressed. So we have to maybe not biopsy everything and keep a close eye on them as they come along. So this is a regenerative nodule, about 1 centimetre in size, and given contrast ultrasound, and we can see that it's enhancing the same as the background liver. on the arterial, and more importantly, on the venous and delayed phase, it's holding on to contrast. So this is a regenerative nodule, and we can follow this up with ultrasound. However, with the HCC, when we come up on our grayscale and we begin to see larger lesions, we give the contrast and we can see multiple lesions on this late arterial phase scan. Or with the smaller, this is just an early arterial phase scan showing a rapid wash-in of a lesion. So when we find a focal liver lesion in cirrhotics, we usually give them contrast to try and help us to characterize it, as we know that because we've got this broad imaging spectrum of these active nodules that are changing, usually we will see a characteristic enhancement pattern, but there will be some overlap. We would have a low risk for follow-up and for biopsy. Again, just a scan from this week. So here's the lesion on the arterial phase. Again, not a brilliant arterial phase MR compared to what you'd get on a contrast ultrasound. Here's the washout in the portal venous phase. Here's the hepatocyte-specific phase. And here's restricted diffusion. So the American guidelines say less than a centimetre, repeat in 3 months. Any change, then off you go with all your other investigations. And if it's stable, go back to routine follow-up. Greater than a centimetre, you need your 4-phase with delayed contrast imaging, whether that's CT or MRI. The Americans at the moment don't recommend using contrast ultrasound because of the overlap between hepatocellular adenomas and HCCs. If there's any question, then they ultimately go to biopsy. So that's it. Pretty much we have an algorithm so that we can say to the patient, you have a cyst, you have a hemangioma, you have fatty sparing, you have a solid lesion, it's likely an FNH or an adenoma. And then the end stage is happy patient and an alarmed radiologist. Okay, so thanks very much. Enjoy your lunch.